The nature designs everything almost perfectly. Just the amount necessarily needed to produce the chemical transmission between across the nerve and muscle. So too much of acetylcholine can produce what we call cholinergic crisis because chronic too much of methanol sometimes can cause muscle problem in itself, but during acute phase, it can lead into a crisis that can also require mechanical ventilation. So sometimes the symptoms are very similar. You can have excessive secretions. You can have, heart rate. The way that we usually check, if the heart rate becomes too low, we say, oh, maybe that's due to too much of the methanol. So one has to be careful because the tendency when the myasthenia start to get worse, patient will start self-medication. I'm going to take more and see whether I can get better. But they should know that when you have to keep taking more, it means to say your immune system is acting up, that it may not be enough. You cannot just keep taking more and more because you can push yourself into cholinergic crisis.
Yeah, basically if you have too much acetylcholine at the neuromuscular junction, basically your nerve keeps firing, it does never shut down. So that can lead to muscle weakness and even lead to a myasthenic crisis. Dr. Sullivan, do you have a typical dose that you want patients to watch out for as far as how much acetylcholine is too much?
Each patient is different. Some patients can tolerate higher dose than others. So you cannot just say, oh, the maximum is this dose. But you, based on the symptoms, we base in where the patients start complaining a lot. If you have a lot of diarrhea, a lot of cramps, you start getting a lot of muscle twitching. And instead of making your myasthenia better, you start getting more secretions. Those are maybe signs that you're taking too much of the methanol.
Incontinence is not a commonly described symptom in myasthenia, but there are reports in the medical literature of patients with myasthenia and have urinary incontinence and what we call atonic bladders. The bladder doesn't contract. As far as the exact etiology, because the receptors in the bladder muscles are different from the receptors that act in the skeletal muscles of the limb and breathing muscles. So as far as I know, the exact etiology why these patients will have urinary incontinence, we're not clear, but it is it has been described in patients, and in those case reports that these symptoms do improve with treatment of myasthenia.
So even though the chemical is the same, it's acetylcholine, but the receptors are different. So presumably, if we take too much methanol, sometimes patients will notice that they have urinary frequency. Okay, they have to go frequently. So sometimes it's the opposite. Instead of it's urinary incontinence from not being able to get there soon enough because they have frequent urination. Okay, so it's like having diarrhea as side effects of the too much methanol.
Unfortunately, there's not a lot of good studies to look at the effect of exercise in myasthenia. But what I would recommend to patients is that they usually, first of all, your myasthenia has to be stable to undergo an exercise program. And then the type of exercise you do should be low impact exercise, things like a stationary bike or elliptical instead of running for miles and miles. Another rule of thumb is that you should listen to your body. If you do a type of exercise for a certain period of time and you find there's a lot of muscle soreness, cramp, and trouble breathing, that probably you should stay away from that type of exercise or the length of duration for that exercise. So listen to your body. Type of exercise such as resistance training, stretching exercises, and such as stationary bike or elliptical are the good ones to start. And aquatic exercise in the water would be good ones to start with.
So the one thing I tell my patients as far as exercise is where they can do weights with dumbbells. I don't want them to be lifting weights while they're lying down, because if they get arms get fatigued, they can get into trouble. And although some patients, I have one patient who is a policeman who's very stubborn and still wanted to do that. But you can imagine if your arms get tired, then the whole thing can come into your windpipe, right? So I agree that low impact exercise will be better. Inactivated toxins, inactivated virus, totally dead, inactivated, those are okay. It's just the live ones that you cannot have. Now, if you're myasthenia, if you're in remission, you're not taking any immunosuppressants, then you could, okay? So although there's always some slight risk in saying, well, maybe since, you know, the goal of the vaccine is to stimulate your immune system to produce antibodies, right? So some patients are always worried, well, will it stimulate it to produce more antibodies for myasthenia also? So that's why we usually tell them, make sure your myasthenia is relatively stable before you start taking these vaccines.
And the CDC has a really good information. It has printed out information on all kinds of vaccines that it also usually it tells you which patients should receive this type of vaccine and which patients should not. And then if someone, they will actually say if you're on immunosuppressant medication, you should stay away from this type of medicine or vaccine.
So it depends on the kind of thyroid problem you have. If you have hypothyroid because you had the thyroid surgery before, probably not. But if you have a thyroiditis, you know, which is also an autoimmune disease, then maybe when you're receiving also steroids, you're also controlling the thyroiditis. So you may actually make your thyroid function a little bit better. So it depends on what kind of thyroid problem you have.
So it's methotrexate has been used in myasthenia, usually for patients who fail other immunosuppressant. You can have, methotrexate comes in an injection, which is typically what it has been used in rheumatoid arthritis. It's been approved medication for rheumatoid arthritis. And I think the trial that Dr. Pascuzzi talked to your friend about is the trial that they're actually using oral medication of methotrexate for refractory myasthenia patients. Like I mentioned in my talk, that so far it's been found to be well tolerated. And some of the side effects that you do need to monitor liver function when someone's receiving methotrexate, and you make sure that you have to have a PPD test, make sure that you don't have TB or latent TB, tuberculosis, before you start the medicine.
Myasthenia gravis that is autoimmune, what you inherit is usually genetic predisposition, not the myasthenia itself, meaning you have a genetic predisposition to develop different autoimmune diseases. Now, you can have the congenital myasthenic syndromes in children that can look like myasthenia, that it's due to particular genetic alteration in one of the proteins that I mentioned. Then those are the ones that can be inherited, okay? So autoimmune myasthenia gravis itself, it's used most commonly what we call sporadic. Now, there are few cases of familial myasthenia gravis, in other words, more than one member in your family with the autoimmune type or the myasthenia gravis type. But in general, it's not a condition that you said you have it, therefore your children, 2 out of 4 is gonna get it, okay? It's a congenital myasthenic syndromes that are ones that are more known to be, can be inherited.
mean, some patients may present years and years after they've started having the symptoms for whatever reason, having no access to the medical doctors, or the diagnosis can be delayed for many years. But we know there are two group of patients who tend to have myasthenia. One is the younger patients, and in that group it's the female patients. And then there's a group of patients that are elderly, and that patients tend to be more male predominant. So if you probably fall into the second group of patients. So I think probably that's a late onset of myasthenia, so probably wouldn't affect when you were younger. If it's medication-induced steroid, I have had patients who their diabetes gone once steroids stopped, or even reduced to a minimum amount. Of course, that doesn't mean that you have to eat whatever you want. You can eat whatever you want. And, still a healthy lifestyle is required.
So in terms of a question earlier about nutrition and myasthenia, that's one area we're in. And to somebody on steroids, you have to watch your diet. In other words, it doesn't have to be necessarily, you just have to make sure that you cut down on the carbohydrates in your diet. And in order not to stimulate, steroid can increase your appetite, right? So you have to avoid sweets, because sweets usually stimulate your appetite. So unfortunately, you have to make your diet a little bit more bland, higher protein, lower carbohydrate. And that can sometimes lessen the amount of weight you gain from steroids.
Yeah, if you're planning to have a child, make sure you let your doctor know, so the doctor can plan ahead of what medication that you will take. Certain medications, the literature and the amount of evidence we have tell us that it's safe to use during pregnancy, and those medications are steroid and pyridostigmine or mestinon. Treatments such as plasma exchange or plasmapheresis and IVIG are also believed to be safe during pregnancy, especially pregnant women undergoing MG crisis. Now, I know in Europe, the practice is a little bit different. Imuran is used in pregnant women, but in the United States, it's still listed as contraindicated in pregnant women, as well as Cellcept or mycophenolate and the other immunosuppressant that I mentioned.
In addition to this, contraindication are not absolute in the sense that the patient really needs it, because your myasthenia really is fluctuating without this medication. Then you just have to weigh the benefits versus the potential risk. One thing is you have to let your doctor know about the myasthenia for two reasons. If you're getting pregnant, because your baby can have a transient neonatal myasthenia during the first few weeks of life, okay? So even though it's a temporary condition, at least you have to discuss this. And there's a small risk that the baby, if there's a certain type of antibodies that are present in the patient, it may have a small chance of fetal abnormality. And so that's why you have to discuss this with your myasthenia doctor if you want to get pregnant. Most of the patients, though, knock on wood, they have gone through the pregnancy okay, no problem, mild transient neonatal myasthenia for the baby. And also during labor, your OB doctor will have to talk to your myasthenia doctor also. Because especially if your myasthenia is not in remission and you're going to be tiring out during labor, so that's why you have to discuss first before you plan your pregnancy.
I would use the safest drug possible to minimize the adverse effect on the fetus. So those would be pyridostigmine. If that's not enough to control the symptom, then steroids. And plasma exchange IVIG depends on the severity of the symptoms.
Neck pain may or may not be symptoms of MG because some patients may, if you have neck muscle weakness, that you feel tired when you're holding your head, they can have some soreness on just from trying to hold your head up. But if you don't have problem with your, any problem with double vision, chewing, swallowing, or neck muscle, it's just arm weakness, that may be from something different, like pinched nerve in the neck. So your doctor will have to do the workup and see whether that's related to myasthenia or not.